not be an unknown to you. He really doesn't require any introduction. He's been a friend to all of us, a lighthouse for the industry. He's been taking charge of what we call translation, so actually using these virtual twins in the clinical arena to actually help the whole team of doctors to improve the outcomes for patients and improve the entire experience for their families. So with that, I'd like to join me introducing Dr. David Hoganson to the stage.
Thank you. Thank you. All right, perfect. Thank you. Great. All right. Well, thank you so much, Steve. It's really a privilege to be here. I've been fortunate to be involved at the Living Heart Project for many years and supported with technology from Dassault Systèmes. And it's not only the Living Heart effort that we've been involved in, but really the 3D Experience platform. And most of what we actually use are the aerospace tools that we've applied in this to solve some challenging problems in patients with congenital heart disease. And I think Michael and Kevin said it well, that the technology is there, right? And the tools are there, the simulation, the computing power is there. It's just a matter of how do we bring that together to solve individual clinical problems. And so that's really what we have done at Boston Children's Hospital, is really try to take these tools, and with few exceptions, we use commercial software, the same software that they use for aerospace and automotive industry. We have just applied it in a clinical way to solve problems for our patients. And so the mission and the calling card of the work we do is about impacting clinical outcomes. And so I'm going to share with you several examples of how we use this software to create workflows for patients to improve their clinical outcomes. So if we look at where we were 8 to 10 years ago, this is a patient with very complex congenital heart disease, and this is images from a CT scan. And as physicians, cardiologists, and surgeons, we really had to take this information, look at it in multiple planes, and then synthesize it in our minds of what was going on. We would add the echo images and the cath images, and then we walked in the OR with only what was in our mind and said, okay, we got to remember all of those spatial relationships. We got to remember exactly what the anatomy is, and then we got to come up with a way on the fly to reconstruct the anatomy to make things absolutely perfect in a very small child. And so this is the approach we take now. This is a patient-specific three-dimensional model made from that CT scan that you saw before, but we made every single element of the anatomy as effectively a different part. And in a 3D viewer, you can essentially take the anatomy apart. You can look at it from any combination of anatomical features. You can look inside, you can look outside, and now you have a whole three-dimensional map, not only to plan the operation beforehand, but to take into the operating room and utilize during the operation. This has been, as you can imagine, an absolute game changer. This is an extraordinarily complicated child who needed to have all the blood supply to her lungs disconnected from her descent aorta, those 6 vessels put together surgically, connected to the heart via conduit, and she was a few months old at the time of this operation. She is now 5. She did extraordinarily well, and I just replaced her RVDP conduit a couple weeks ago, and she's doing great. So this has really been a transformation of what we used to do into an entirely new paradigm. We use these models in the operating room for intraoperative guidance. We have a sterile controller. Some of you with small children will recognize that. That's a Nintendo Switch controller, which we reprogrammed as a mouse. And we use this in the operating room. I was in the operating room this morning, and I used the 3D model to sort out the anatomy and to guide the operation. It's really the gold standard at Boston Children's right now. But the 3D models are beautiful and obviously elegant and help us plan these operations in a very qualitative way. But I think what really makes a difference is how can we use these tools to plan these reconstructions and these reinterventions in a very quantitative way. I'm an engineer. We have a team of engineers, and really what we need is how do you take these complex reconstructions and deliver the surgeon an exact plan, the patch that's the exact size, the exact shape that's going to accomplish this repair and have an outstanding both short-term and long-term outcome. And so this is really the focus essentially the push as to how do we take these engineering tools and make them a mainstay. So this is a patient with super complex anatomy. The orange structure you see is the left ventricle. The job of the left ventricle, of all of you in the audience, is to pump the blood to the body. In this patient, the aorta, the blood vessel that delivers blood to the body, comes off the right ventricle, which is in purple. And so for this patient, we needed to redirect the blood from the orange left ventricle over to the aorta to restore normal physiology. And in the past, we would just figure this out in the operating room, and now we can actually plan this out. So this is looking inside the left ventricle, and you can see there this green patch is the patch that we need to redirect the blood flow from the left ventricle through the right ventricle. It has to go right under the aortic valve, shown in red, right over the tricuspid valve, shown behind in purple, and right below the right ventricular outflow tract, which is right in front of it. It also has to not injure the valve and miss the electrical system and not cause heart block. It essentially has to be perfect. And so what we can do now is plan these patches utilizing the 3D model, which is an engineering quality, dimensionally correct representation of the patient's anatomy, and then use engineering tools to design the patch, and then use aerospace tools to create the mathematical equivalent of the flat patch, because most of our patch materials are flat, and then take that into the operating room. And then we borrowed another aerospace trick, which is a laser they use to position aircraft parts. We use it to project the patch design down onto the sterile patch material. This is in the operating room. We trace it out, we cut it out. It takes about 2 minutes, and we sew the patch in. And that allows us to translate with incredible precision, in fact, less than 2% error from the design on the computer to the traced out and cut out patch that we use to sew in place. And so this is now something we've expanded from a few patients to many, many patients and many different workflows. This is a patient who has some of the pulmonary venous return, the blood coming back from the lungs, didn't go to the left atrium, it went to the right atrium. And you can see there highlighted in yellow is both a vein that connected to the superior vena cava in the wrong spot and also is narrowed. And so with virtual surgery, what you can see is we've enlarged that orifice virtually, mimicking what we'll do surgically, and now we can design patches to baffle that pulmonary venous flow over to the left atrium. The pulmonary veins are extraordinarily sensitive. If you get the shear stress wrong, if you kink the patch, if there's any aberration, it will start a biologic process which they will narrow, and it becomes really a huge challenge to correct that. And so we've done this many times and is now a mainstay in taking care of these patients. This is another patient who has really complex anatomy. Again, the left ventricle is in orange, the right ventricle is in blue, and the aorta comes off the right ventricle, and there's a ventricular septal defect or a communication, a pathway, if you will, where we can redirect the blood flow from the left ventricle up to the aortic valve. We need to create that pathway just perfectly, in fact, remove some of the muscle shown there in teal, and we can plan this all out before the operation. And this is the patch that we're going to put in that after we resect the muscle to create that adequate sized pathway through the right ventricle up to the aortic valve. And this is looking down from the aortic valve. We've achieved an adequate sized pathway for this patient. So this is really a mainstay of how we do these complex patients. This is a patient actually from a week and a half ago who we did this operation and has had a really beautiful outcome. In other patients, we have to redirect the blood flow within the atria or the upper chambers. This patient needs an atrial switch to redirect the blood flow from the superior vena cava and the inferior vena cava over to the other atrium and the pulmonary venous flow into the teal atrium. And so we used to, again, make all these complex decisions on the fly in the operating room, and now we can plan out these baffles ahead of time. So this is, you can see in green is one of the baffles from the SVC. The orange is a baffle from the IVC, and we can plan that out completely ahead of time. And not only conceptually, but we can plan that out dimensionally and take those plans into the operating room. You can see the SVC baffle there, and this is the inferior vena cava baffle. And again, how these baffles fit in with the atria. So this is also a patient from this month who we took those plans, uploaded them in the laser, projected down onto the patches, traced them out, cut them out, and sewed them in. So really remarkable step forward for us. And this is not really something that just benefits Boston Children's Hospital. This is a tool to to make it available for other surgical groups who maybe haven't taken on these kind of cases. And maybe instead of doing a complex biventricular repair to restore normal circulation, would do an easier operation but end up with a less robust circulation, a single ventricle circulation. So this really is a tool to be able to democratize some of these complex repairs to children who need it all over the world. Another area we've tackled, which is really challenging, are the heart valves. This is a 3D model of a mitral valve in the closed position when the heart is squeezing. We've been able to model these now in the closed position and in the open position, and really pick apart the mechanism of why these valves leak or are narrowed. In children, it's incredibly important to repair the valves because they have to grow with the children. If you replace it, you will replace it and replace it and replace it again. And so repairing them is of utmost importance. And so now we have a way to make these really elegant and very complex mitral valve and AV valve models. And we've done it close to 150 times in patients. And it's really revolutionized some of the repair in these complex patients. And so this is one of the areas that we're really pushing forward. And we have another program in aortic valve repair also. So now we're not only creating these models, but we're planning the valve repair down to the millimeter. So when we repair an aortic valve, we actually go into the operating room with the exact dimensions of the leaflets that we need to reconstruct, the size of the supporting diameter of the aorta at the leaflets called the sinotubular junction, the size of the annulus. It's all planned out to the millimeter. We go in with a very exact plan and we execute that plan knowing if we restore the normal geometric relationships of a valve, it's going to work. And the reason it doesn't work is those geometric relationships that made the valve work in the first place have been lost. And so we've been able to do that in over 100 patients for the aortic valve with really exceptional results. And now we're applying those same quantitative planning approaches to the mitral valve. And again, not only does it help us as surgeons at Boston Children's, but it helps democratize some of the more complex techniques to programs all over who can apply them for their patients. I'm going to share with you some of our work in using computational fluid dynamics to help clinical decision making in patients. And this is an area, ironically, where we started. This is the very first thing we did as a modeling team at Boston Children's Hospital, recognizing this is a huge clinical need for some complex patients where you literally, as a surgeon, you don't know what operation to do based upon the complexity of their anatomy and trying to get the flow right. So this has principally been done in patients with single ventricle heart disease in a circulation called the Fontan circulation, where the blood flow is redirected to the lungs in a passive way, so there's no pump. And the one ventricle, whether right or left, is organized to pump the blood to the body. This circulation depends upon everything working very, very efficiently. And the blood flow needs to be distributed in a normal way to both lungs, and the energy loss in the throughout the connections has to be very low for this to work. And so what we've done is we've created a whole program to be able to both create these patient-specific 3D models, but then also model different surgical options in these patients, because truly we don't know exactly which one is going to work best for this patient given their complexity. And so we can create these virtual surgical models, but we can also then model the physiology of this exact patient. So we use flows from the MRI, we use pressures from their catheterization, and we create essentially a mathematical model of who they are physiologically. And so then when we run the computational fluid dynamics through these different virtual surgical options, we are not modeling, okay, in some hypothetical sense, what might happen. We are modeling what we exactly expect to happen if we do this operation on this child. And we've gone to great lengths to be very precise about how we model each patient's individual physiology. So we are predicting what we think is going to happen in that individual patient. And that has really paved the way for us to be quite confident in what these results show. So I'll share you a couple examples of how we do this. So this is a patient who came to us who already had this Fontan procedure, and she had developed complications from it because the flow distribution to the lungs was not well balanced. And in fact, she had developed very low oxygen levels and was probably not going to survive more than another year if something wasn't done. And so on the far left, you can see her existing anatomy, where in fact all the blood flow from her liver was going to one lung, which was the source of her problems and the low oxygen levels created by issues in the other lung. And so we modeled what we would have done as a first or second surgical option shown there in A and B. And you can see that one solution kept all of the blood flow going to the right lung, and the other solution just created a different problem and put all the blood flow to the left lung. And without any of these modeling opportunities, we probably would have done option B. And in fact, we would have had a problem in the right lung a few years later. And so with this, we're able to really undertake an iterative process by saying, okay, let's look at the modeling results and when necessary, continue to alter the surgical plan to achieve the target. And so in fact, we eventually created a surgical option that worked well for her. She underwent that option, that surgery, and had a very nice outcome. This is another patient with a lot of complexity who needed this Fontan operation in the first place, and recognizing some of the challenges of their anatomy, we thought that the standard approach, which would have been option B, would have been potentially challenging. And you can see in that option, nearly all the blood flow from her liver went to her left lung. And so we kept looking at different options, and in fact went with the option in red, had really nice balance of blood flow to the lungs, and this young boy underwent this operation and had a very nice outcome. And so I think a lot of what you heard before is developing that trust, and the trust not only for the engineering team who's doing the modeling and simulation to know that the results they're putting out are correct, but for the whole community. In this case, for us, it's the clinical community. So are we producing results that are trustworthy, and can we use these for clinical decision making, or are we not? And so not only have we've been very meticulous to create these models using patients' own anatomy, but we've been very careful to try to validate these with real clinical data. And so this is some data I presented at a scientific conference in June where we looked at MRI results of patients after this Fontan completion or revision, where we had done modeling and simulation and said, okay, how good are we at predicting what's going to happen? And this is not looking at just the accuracy of the computational fluid dynamics. That is important. We know CFD is accurate, right? It is taking into account the whole process. How well did the engineering team interface with the clinical team, come up with a solution, come up with an operation the surgeon was actually going to do, help that surgeon achieve that operation in the operating room with intraoperative guidance with the 3D models, and then achieved the exact clinical outcome that we were looking for. So it's the whole process. And what you can see here is in this group of patients, the computational fluid dynamics predicted a flow balance pretty even to both lungs, and the MRI measured pretty close to that, but the per patient percentage point variation was only 7%. And so I think this was super encouraging data that captures the entire process and has given us and the community a lot of confidence moving forward. As you learn from other patients, the blood flow distribution from the liver is also super important in these patients. It is not directly measurable by MRI with the current approaches. We're working on that. But we redid computational fluid dynamics with the post-op anatomy and the post-op flows and found a percentage point variation of 16% for our hepatic flow distribution, which was also very encouraging. I'm going to share with you one more challenge that we've taken on, is that as these patients who have a Fontan grow older, the clinical approach is once you get your Fontan, you're done surgically and everything else is medical management. And many of these patients have run into challenges as they've grown older and need to be considered for Fontan revision. This is one of the drivers of those challenges. When you get the Fontan operation, the upper body sends twice as much blood back to the heart as the lower body, just because that's the ratios when you're young at the age of about 2. By the time you're 8, that flow is balanced. By the time you're 15, the lower body has twice the return of the upper body. And so when we're doing these connections, what we've seen is the energy loss across these connections go up as you get older. But again, this is a passive circulation and it has almost no tolerance for excessive energy loss. And so whether you do an extracardiac type Fontan or a lateral tunnel type Fontan, that energy loss goes up. And so what we've started to do is look at these patients and say, we shouldn't just sit on our hands, we should fix them, and we should make their pathway bigger. And so the question is, how big should we make it? And what we've seen is that in these patients, we can use computational fluid dynamics to look at what's the right size of pathway for this patient and this conduit size when they're older. And so what we've seen is as many of you would predict, right, there's an optimal size, and if you go above that size, you actually start to lose efficiency because there's swirling of blood and flow separation in the conduit. And so we've seen this consistent pattern that there's an ideal size, and then the efficiency wanes if you put too big of a conduit in. So this is a patient who's an 18-year-old who had a narrowing, as you can see in that upper left, of her Fontan conduit. The local team said she is fine. She wasn't fine. She was having a lot of issues and really poor nutritional status. She was about a little less than 90 pounds as an 18-year-old. And so we ran the computational fluid dynamics, and you can see here her energy loss had an 8-fold improvement from where she was to, if we upsized her, to a 22-millimeter conduit. So she underwent this operation about 2 weeks ago. She's going home tomorrow, and she's going to be a totally new kid. So it's really exciting to see the computational fluid dynamics. It's fabulous science, right? But we're using it to make a real impact in the lives of patients, and that's very, very important. Our effort at Boston Children's has grown quite dramatically, and so this is the patients who've gotten a three-dimensional model before their procedure and used to plan their operation. This is through 2024. We're on track in 2025 to do 630 models, which is about 60% of our surgical volume. So most of the patients at Boston Children's Hospital, we might have a little more complex case mix than some, but most of our patients get a 3D model, and about 20 of those get some degree of advanced preoperative planning with patch planning or flow simulation. And this all takes an incredible team to do this, and as the need and the requests have grown, we have grown our team, and so this is our team of engineers at Boston Children's Hospital, and I think I cannot more strongly echo what Kevin said about the importance of the engineers being deeply involved in the process. Our engineers are in the operating room every day. They play a vital role in the clinical conferences and really understanding these problems and creating solutions that are really going to solve the problems and not just an academic solution. So it's been a real joy to apply modeling and simulation clinically, and I'd be happy to take any questions.
I have no words. I can, on behalf of all of us, thank you for modeling the future of medicine. There's nothing more that I can say. You're returning physics to the physicians, and I think that's a really beautiful thing, so thanks.
Thank you. All right.